Hi all, today we are going to discuss about pathology basic sciences part 1 for some general surgery residents university exam based questions. Disclaimer is given in the description. Let's move on to the video. Watch this video at 1.25 speed. So if you know the physiology, you can able to answer the pathology. So to write a pathology question, first write the definition, what is the inference, what are all the uses, what are all the limitations. So in that format you write. So with respect to the FNAC, it is a cytological study of the tumor cells to find out the disease and also to confirm whether it is malignant or not. We can use 23 or 24 gauge needle with a lump held firmly. The needle is passed into the lump and with a negative pressure, continuous aspiration is done. Suction pressure of 40 cm of water is created into the syringe. The material is collected on a slide. Smear is made using 100% alcohol. Minimum 6 aspirations done. And stains that we use: Gemsa, Papinoculum stain, Hematoxylin, Eosin stain. Repeat FNAC can be done for 2 times. The advantages: it gives only cytological diagnosis, least painful, done on OP basis. Malignant deposits will not occur along FNAC track. Limitations and its disadvantages. It is difficult to differentiate between invasive and in situ cancer by FNAC. It is absolutely contraindicated in a testicular tumor because tough tunica albuginea usually prevents tumor spread once it's disrupted by FNAC. Receptor study cannot be done. So, like if we can't perform immunohistochemistry and we can't able to differentiate between follicular neoplasm, follicular adenoma and follicular carcinoma, there is one catch: it is absolutely contraindicated in testicular tumor, right? But in which stage of testicular cancer we can do FNAC is T4, as the testicular tumor reaches or scrotal involvement is present. Now we perform FNAC. This is one important catch we must remember. So what are all the pre-malignant lesions of oral cavity? So I want you to remember one point. So what do you mean by a pre-malignant lesion and a pre-malignant condition? See, the point here is pre-malignant lesion is a morphologically altered tissue in which, like in case of oral cancer, is more likely to occur than its apparent normal counterpart, whereas a pre-cancerous condition is a generalized state. Pre-cancerous condition is a generalized state associated with a significantly increased risk of cancer. For example, a radiation exposure is a generalized state in which there is an increased risk of cancer. A pre-malignant lesion is a morphologically altered tissue in which oral cancer is more likely to occur than its apparently normal counterpart. So what are all the high risks? Leukoplakia, erythroplakia, chronic hyperplastic candidiasis. Medium risk: oral submucous fibrosis, syphilitic glossitis, sideropenic dysphagia, which is your Plummer-Vinson syndrome, where you will be having esophageal web, dysphagia, iron deficiency anemia. Equivocal risk: oral lichen planus, disc keratosis congenita, discard lupus erythematosus. In this, the precancerous lesions are leukoplakia, erythroplakia, erythroleukoplakia, oral submucous fibrosis, oral lichen planus. All others are precancerous conditions. So with respect to the mesenteric cyst, I discussed the anatomy of mesentery in the basic sensus anatomy video. The mesentery originates from the L2 left lateral border, and from there it is attached to the right sacroiliac joint. Thereby it will crosses DJ flexure, supramesenteric vessels, ureter and psoas muscles. And the mesenteric cyst is of two types: chylolymphatic cyst and enterogenous cyst. I want you to remember these 2 points and Tillog's triad. See, the name itself implies enterogenous cyst, so it is arising from the bowel. Chylolymphatic cyst as an individual blood supply. It is arising in a separate fashion. Let's look into the discussion. The chylolymphatic cyst is the most common type. It is mainly because of congenital misplaced lymphatic system and does not have efferent communication into the lymphatic system. More common in ileum, a thin-walled cyst with a flat endothelium. It is solitary, unilocular. It has got independent blood supply, so enucleation can be done. They are often called as non-neoplastic mesothelial cyst. It is occasionally may contain chyle, even though serous fluid is the most common content. It is enucleated surgically, whereas enterogenous cyst is arising as a diverticulum or a duplication from the adjacent bowel. It is thick-walled. It receives its blood supply from the adjacent bowel, so resection should be done. Enucleation not done. So what do you mean by Tillog's triad? A soft intra-abdominal umbilical mass which is mobile in the direction perpendicular to the attachment of the mesentery. Attachment of mesentery is like this. It's mobile in this direction perpendicular to the attachment of mesentery. Resonant mass. It may precipitate intestinal obstruction and valvulus. So what do you mean by sentinel lymph node biopsy? The first axillary node draining the particular portion, for example breast, by direct drainage is designated as sentinel lymph node. So it is the first lymph node involved by the tumor cells, and presence or absence of its histological involvement. It will give a predictive idea about further spread of the tumor to further nodes. If this first echelon node is affected, then it is metastasis. The incidence of involvement of other node without sentinel lymph node is less than 3%. If SLNB is negative, nodal dissection is avoided, but follow-up is needed. It's done in all cases of breast cancer T1 and T2 without clinical palpable node. Not done in clinically palpable axillary node as it is palpable, and in cases of multicentric multifocal tumor as there is distortion of the lymphatic blood flow to the tumor. Sentinel lymph node is localized by the method isosulfone blue dye or technetium 99M radioisotope label albumin near the peritumoral area or subdermal plexus around the nipple, and we have to detect with gamma camera. Frozen section biopsy or touch imprint cytology is done for the presence of malignant cells. SLNB is done in CA breast, CA penis, malignant melanoma. It's contraindicated in patients who are allergic, pregnancy, and inflammatory carcinoma of the breast, as the derm is infiltration by the tumor cells. So what are all the tumor markers? So markers are biochemical indicators of the presence of a tumor. They are of a prognostic value. So there are 4 types. Category 1 is hormonal, like human chorionic gonadotropin, calcitonin, catecholamine, ectopic hormone production. Human chorionigonadotrophin in case of trophoblastic tumor. Calcitonin, which is secreted by the parafollicular C cells of thyroid. Medullary carcinoma of thyroid. Catecholamine by pheochromocytoma. Ectopic hormones, like in the case of small cell carcinoma of the lung, presenting with syndrome of inappropriate antidiuretic hormone secretion causing dilutional hyponatremia. Category 2, prostate specific acid phosphatase, which is in the case of CA prostate. Neuron specific analysis in the case of small cell carcinoma of lung or a neuroblastoma. Category 3, which is your oncofetal antigens or alpha fetoprotein. AFP is mainly in hepatocellular cancer, non-seminomatous testicular tumors. Carcinoembryonic antigen in case of carcinoma lung, carcinoma pancreas or lung carcinoma. CA125 in ovarian cancer, CA15-3 in breast cancer, 19-9 in case of colonic cancer, CA72-3 in case of pancreatic cancer. CA72-4 in case of colonic cancer. So what are all the types of biopsy? The multiple types are there: incision, excision biopsy, true cut, pap smear, FNAC, frozen section and punch biopsy. And even image guided biopsy like ultrasound guided, CT guided, laparoscopic and thoracoscopic endoscopic biopsy, proctoscopic biopsy and open biopsy. Excisional biopsy and incisional biopsy: when the entire tumor is removed, the procedure is excisional. Only a portion, it is incisional. Edge-wedge biopsy comes under an incisional biopsy. Incision biopsy is taken from the edge of the lesion in ulcer, not from the center, as there is necrosis. So it is an edge-wedge biopsy, which limits edge is a line which limits two parts. Wedge is an area of two meetings, parts like thick to thin. Incision biopsy is contraindicated in case of melanoma, where excision biopsy is done. In secondaries, FNAC is preferred. True cut biopsy, it is done using a specialized device wherein gun with a true cut tip 16 to 18 gauge is inserted into the surface tissue or organ, and gun is fired close to the punching tip of the needle to catch and cut adequate tissues. Frozen section biopsy is done whenever biopsy report is needed at the earliest. So unfixed fresh tissue is frozen. It is technically difficult. Often it is difficult to give accurate results, but the advantage is quick and surgeon can decide further step of the procedures. It is done in the CA breast or in case of follicular cancer of thyroid when FNAC fails. During surgery, after resection of the tumor, the clearance in the margin and the depth, and also to study the lymph nodes for their positivity. This is a very important anatomy. So